Good morning, everyone, and welcome to one more lecture of regarding urology. In this one, I'm going to talk about all the tests which we can do for in nephrology, which can help in the diagnosis. Of course, there are many tests. We cannot talk about all the tests, but the commonly used tests in nephrology, which we do. So, I would like to talk about first of all about urine dipstick. So, as you can see in front of you, that urine dipstick is a office test which can be done in the offices, and GPs have this thing. And the bottle looks like this, and there is a strip which have different colors on that. So if you can see over here, of course, like it's hard to read, but it says like leukocytes, and then there is nitrite, then there is urobilinogen, then there is protein, then there is hemoglobin pH, then there is hemoglobin, there is specific gravity, there is ketones, there is bilirubin, and there is glucose. So when we open this thing, it looks like this. Rather, I will make it a little bigger for you guys so that if like you can watch it clearly. So this is how it looks like. Okay, this is how it looks like. So this is like, you can say, something standard, but of course, like different companies, they make different type of different companies are there. So there are different strips which are, of course, there available in the market. So what is done, like we just ask the patient to uh, urinate, and then we immerse this strip which I have shown you. Okay, uh, and then when after immersing, we take it out from the urine sample. It takes like 2 minutes, like 1 minute to 2 minutes. You can see over here 120 seconds is 2 minutes, and 60 seconds is 1 minute, and 30 seconds is like half minute. So maximum it takes 2 minutes, uh, to perform this test. Okay, and now this strip is basically have different reagents which react. For example, this part of the strip basically have a reagent which will react to glucose. This one have reagent which react to bilirubin. So same like with all these things, that they have the reagent which react to certain thing. So now what happened, uh, once we take it out, we see the color changes. We see the color changes, and we see how much the color is changed. You can see over here, different colors are there. Okay, different colors are there. So we see, number one, either there's any color change, or the second thing we see is how much color is changed. Very, very, very useful. A screening test to check for infections, diabetes, ketones, hematuria, proteinuria. So guys, it's a screening test. Of course, like once you have certain result, you have to check it in the labs as well. Okay, so the pH, as you know, there is a thing for pH as well. So you know what is pH, and the kidney is playing the part in pH in controlling pH as well. Bicarbonate and hydrogen ions, right? So a very helpful thing to check, like either the patient is having any acidosis or alkalosis. Then there is for specific gravity, and again specific gravity is very important. If you know about diabetes insipidus, for example, okay, we can check this one. Very, very, very helpful. There is blood We can check for hematuria, and we can simply see like how much blood is there. Okay, see what is the cells per microliter. So 200 cells, 80 moderate and 25 small, and 10 is like traces. So simply we can identify a lot of conditions, in this regard. A very helpful thing is nitrite and leukocyte test. It's very 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 helpful in identifying this thing. So a lot of things, we can identify. Ketone urea occurs as a complication of diabetes mellitus, if diabetic ketoacidosis, or in starvation, for example, the patient may have uh, ketoacidosis. Even in dehydration, the persons, they have what you can say ketosis. Ketosis can be there. So to tell you, the first one is leukocytes. So there are some leukocytes which are present in the urine. Okay, and the females have, by the way, more leukocytes in their urine because of vaginal contamination. And what is there is basically this test strip detect leukocyte esterase. Okay, it detects leukocytes esterase. So the bacterias, whenever they are present into what you can say uh, whenever like there is UTI, so of course there will be bacteria, right? So normally uh, our urinary tract, they don't have this esterases. Okay, so whenever there is bacteria and there is leukocyte esterase is present, okay, so it indicates like there is bacteria in the urine, which means like there is uh, UTI. Okay, so this thing is like the function of checking leukocytes. Okay, or like if leukocytes are there, of course, like um, what you can say, because if leukocyte esterase is there, so of course it will become come back as positive for leukocytes, which will point towards like the patient have infection. And what about nitrite? Again, the first two is like to check for the UTI, and most of the time this is done to check to catch the UTIs, this urine dipstick. So the most common cause of UTI is E. coli. More than 80% of the infections, 90% you can say, are caused by E. coli. Okay, like a very good mnemonic to remember UTIs is keeps. K is for Klebsiella, E is for E. coli, then there is E for Enterobacter, then P is for Proteus. Okay, this is like a very good mnemonic. So all this organisms which I'm talking about, which are basically gram negatives, they have the enzymes that reduce nitrate to nitrite. Okay, the most common organisms which causes UTI, they have enzymes to convert nitrate into nitrite. Okay, so simply whenever like anyone have this thing positive, okay, it means like the person have UTI. But remember, like guys, gram positive bacteria, they cannot convert the nitrate to nitrite. So if anyone who have gram positive infection, so of course they will be having leukocytes will be positive, but this one will be negative, right? So this is a very 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 important thing uh, to check. Okay, so this urine dipstick is for screening purposes, guys. Remember this thing. For example, if this thing will come back as positive, so you will take one more urine sample at mid catch. We ask the person to go and collect the sample, let the first half of the urine to flow in the toilet, collect the middle half, and then the last half again discard that. This is called as to catch clean sample. For example, babies who cannot do this thing, in that one we collect the urine by either suprapubic aspiration or by by passing a temporary catheter. So this is for screening purposes. If, for example, someone have this thing positive, we will send the urine to the lab to check for glucose. Someone who have this thing positive, we will send the urine and the blood. Someone who have this thing positive, we will send the urine to the lab for more analysis to check what kind of infection is there, what kind of organism is there, like this. Okay, so very, very, very helpful. This urine dipstick test. So once you have done this thing, the other thing is urine analysis. So urine analysis, again, you can use a dipstick. You can send it to the lab. So these are the things we check. For example, we check the specific gravity. Okay. So values of less than 1.010 reflects dilute urine, and value of greater than 1.020 reflect concentrated urine. Value usually 1.010 in end-stage renal disease is called as isostenuria. pH, I already told you the thing, urine pH is normally between 4.5 to 7. If persistently alkaline, consider renal tubular acidosis. If someone urine is alkaline, or consider UTI with urease producing bacteria, protease, for example, because they make the urine alkaline. So whenever you have to do urine analysis, I always tell you that, I told you already that, we always ask the patient to send the urine to the lab and get the confirmed reports. Glucose, I think you guys know what is that, It is freely filtered at glomerulus and reabsorbed in the proximal tubule. And causes of glycosuria include hyperglycemia, increased GFR, like for example in pregnancy, and proximal tubule dysfunction, like Fanconi syndrome. And proteins, again, dipstick only detects albumin, and other proteins like benzones or immunoglobulins or Tom horse fall may be missed. And what is microalbuminuria? I already explained in the previous lecture, 30 to 300. And sulfosalic acid detects all proteins in urine by precipitation. And gold standard is, of course, like this thing we already discussed, 24-hour urine collection for total protein, but very hard to collect 24-hour urine. Leukocyte esterase. And what is leukocyte esterase? I told you these are the enzymes found in the WBCs. And whenever they are present, it means like there is UTI, right? So other than that, you can see the presence of nitrites. In nitrites, you will see that nitrates and urea in urine are converted by bacteria to nitrites. I told you gram negatives almost all. Positive dipstick for leukocyte esterase and nitrites is 94% specific for diagnosing a UTI. Okay, so now ketones, I told you it is positive in alcoholics, diabetic ketoacidosis, starvation, and fasting. And hemoglobin, we will go for a urine dipstick, and then we will go for a urine examination, right? So now the important things is which we are going to cover more in this one. Urine microscopy. So whenever we go for urine microscopy, guys, what we do is, first of all, is like they do microscopy, right? And they see what kind of cells are present. Either it's red blood cells, either it's white blood cells, either it's something else. So When the urine have active sediments, it suggests like that there is parenchymal kidney disease. For example, if there is red blood cell cast or white blood cell cast or muddy brown cast or epithelial cell cast, okay, means like there's some parenchymal disease. But if someone has like hyaline cast or you can say crystals, and the red blood cells or white blood cells are very much less, then there is less likely that the patient have parenchymal kidney disease. So of course erythrocytes, they will see red blood cells. Normal ranges up to 2 or 3 RBCs. HPF is like high power field. So hematuria when the cells are more than that, and if the RBCs are dysmorphic or RBC casts are present, I told you it means they are coming from the glomerulus, right? Very important thing. And if like the cells RBCs are intact, not broken, then it means it is extraglomerular bleeding, like bladder carcinoma or any carcinoma in the tract. Leukocytes is up to 3 WBCs per high power field. Pyuria is when it is more than 3. It indicates inflammation and infection. Very straightforward. And if persistent sterile pyuria is present, for example, like there is WBCs, but you cannot any culture any bacteria, then consider chronic urethritis, prostatitis, interstitial nephritis, calculi, and the other things. Eosinophils, we use these stains to detect eosinophils, okay? And whenever eosinophils are present in the urine, they show that the person have allergic interstitial nephritis. Whenever there is oval fat bodies are present in the urine, which means like the renal tubular cells are filled with lipid droplets, they are seen with heavy proteinuria in nephrotic syndrome. So these are the cast cells I was talking about. Casts are basically, these are cylindrical structures formed by intratubular precipitation. Okay. So if the hyaline cast is present, it is physiological, like concentrated urine, fever, exercise. Red blood cell casts are present, I told you it is glomerular bleeding. White blood cells are present, it means like there is infection in the kidney, like pyelonephritis, or inflammation like interstitial nephritis. If there is pigmented granular cast are present, then think about acute tubular necrosis, acute glomerulonephritis. If fatty casts are present, it means there is heavy proteinuria. And there can be the presence of crystal in the urine, like uric acid crystals are present. Think about hyperurics like gout. Calcium phosphate are present, it means the urine is alkaline. Calcium oxalate, consider hyperoxaluria or ethylene glycol poisoning. And when sulfur are present, simply the patient may be taking sulfur containing antibiotics. So we can do this thing. One of the things which we can check in the patients, in the people for urine problems, is urine electrolytes. Now kidneys are the one which are maintaining all the electrolytes, like so simple and so easy. So the most commonly measured like electrolytes are sodium, potassium, chloride. We also check osmolarity as well as the pH. And there is no normal values. Why? Because of course there is normal values in the blood, but not in the urine, because kidneys are the one which are balancing. So for example, if there's no need of too much sodium in the blood, so it is going to throw out simply. Okay. So remember there is no normal values, guys, but there is comparative values. See, electrolyte excretion depends on intake and current physiological state. Therefore, results must be interpreted in the context of patient current state. For example, this one, ECF volume depletion. What is ECF volume depletion? Someone who is dehydrated, okay? Someone who is uh, extracellular fluid volume depletion is there, right? So what it means, see, we should expect low urine sodium. Why? Because the kidneys should be retaining sodium. The sodium is needed inside the body. So if in this condition, if you found that the urine sodium is more than, sorry, it's not 40, it's basically 20 millimole per liter, okay? So the kidneys should be retaining sodium, but the kidneys are throwing too much sodium outside. What it means, the kidneys are not functioning fine. So it suggests a renal problem like salt wasting nephropathy, or as a result of a diuretic, because diuretics action is to throw out sodium, decrease the blood pressure, decrease the volume in the body. And if we expect like urine sodium is less than 20, okay, which suggests the patient is pre-renal, like the kidneys are working fine, they are doing their function, they are retaining the sodium. I hope you understand. This is a very important example. Or, for example, again, this is one more example. Daily urinary potassium excretion rate should be decreased. Okay, like less than 20 millimole per day. In the settings of hypokalemia, because there is hypokalemia. So of course, like the kidney should not lose more protein, more potassium. So if higher than 20 millimole per day, so again, what it suggests renal contribution to hypokalemia. Kidneys should be retaining potassium, but still, if the kidneys are losing potassium, it means the issue is with the kidneys. And so these two are good examples, for this thing. So osmolality is useful to estimate the kidney's concentrating ability. For example, take the example of diabetes insipidus. If the person is dehydrated and if the kidneys are still making dilute urine, again the problem is with the kidney, because the kidney should make concentrated urine in the time of dehydration. Okay, fractional excretion of sodium. This FENA is basically fractional excretion of sodium, refers to the fractional excretion of sodium, right? So fractional excretion of sodium less than 1% suggests the pathology is pre-renal. Okay, so one of the thing, for example, we also check the urine pH. I told like what is the normal urine pH? It is between less than 7. So now, for example, if there is low serum pH, okay, so what we must expect, the pH of the urine should be low as well, okay. But if we found a high pH in the presence of low serum pH, what will happen? What it means, like that maybe the not maybe, like surely the kidney have renal acidification defect, or you can say the renal tubular acidosis can be there. Okay, so this thing, like this one, see, low pH less than 5.5 in the presence of low serum pH is appropriate renal response. A high pH in this setting might indicate a renal acidification defect or renal tubular acidosis. A very, very, very important thing. So, like these are the few of the investigations we do. So, of course, like this week we are going to cover just these topics, and like the next week we are going to start with the conditions. We will study acute kidney failure. We will injury. We will study chronic kidney injury. We are going to study what is dialysis. We will study what is glomerulonephritis. We will study what is like all these conditions. Okay, in the coming weeks, of course. So there are other investigations as well. Okay, you can do the urea creatinine. I already talked about that. You will do the urine analysis, as well as there is a lot of other investigations which we can do for kidneys. For example, we can do a CT scan, we can do the ultrasonography, we can do a X-ray, we can. There are different tests we can do for to check how the kidneys are functioning, to check the clearance of different things. So there are a lot of investigation which we can do to check for the renal diseases. So of course, like what I'm talking about until now is basics. So in nephrology, acute kidney injury, chronic kidney injury, or chronic kidney disease, you can say, what is renal replacement therapy, what is glomerulonephritis, what is nephrotic syndrome, what is nephritic syndrome, what are the renal tubular diseases, what are the inherited kidney diseases like adult polycystic kidney disease. All these conditions are very important. So of course, like we are going to cover up them in the coming days. Okay. uh, Nephrology again, like it it looks like hard, like to be honest, but if you will make good concepts, guys, the things will become easy. For sure they will become easy. They like, especially when we will go to the topic of glomerulonephritis, you are going to have a lot of uh, difficulties uh, in understanding the conditions in the start. Okay. So there are common sign and symptoms which we are going to study, like side by side, because there are sign and symptoms for chronic conditions, and there are sides like there is basically no sign and symptoms for acute kidney conditions. Like the sign and symptoms I'm talking about, rather that there is more lab findings for acute kidney diseases. Like if someone have acute kidney failure, so maybe just you will found the blood and urine abnormalities, but someone who have a chronic kidney failure, of course, you will find a lot of peripheral signs and symptoms. Many of the glomerular diseases, they are a part of, you can say, rheumatological diseases or connective tissue diseases. So, GFR is a test of function, okay, and urine analysis is a test of function, and then there are tests of structure like ultrasound. One very important test we can do is called as intravenous urography. What we do is like uh, we take the imagings by giving some dye the patient, okay, and those dye basically tell you or outline the collecting system, the ureters, and all these things, okay. So after giving the dye, we can take an x-ray, we can do a CT scan to take a look uh, of the kidney structure. So we can take an early image like 1 minute after injection to check for the renal perfusion. We can take a late image when things are in the collecting system. Same thing, there is something called as pylography. So in pylography, what they do, they directly inject the contrast medium into the collecting system, and then they take the images. But remember, guys, like whenever there is contrast are involved in taking these kind of investigations, there are some side effects as well, because the contrast can cause some allergic reaction in many people. So like this. Then there is investigations like renal arteriography and venography. Like these is just to check the renal vein and artery, because there is a condition called as renal artery stenosis, in which the artery is stenosed. So we can do that thing. It could be therapeutics. Like sometimes this one is used to open a closed artery. MRI can be done, and nowadays, radionucleotide studies are there. Uh, so other investigations, what I talk about is pylography, intravenous uh, urography, ultrasound, CT, MRI. Okay, so all these things can be done. Other than that, like I was talking about the radionucleotide scan. So there are two types of scan. One is called as DTPA scan, and one is called as DMSA scan. So what is DTPA scan? It is basically diethylene triamine pentaacetic acid. DTPA, diethylene triamine pentaacetic acid. So what they do is, like, this one is to check the functionality of the kidney. Okay. So DTPA scan, what we do is, like, they give this acid, they label it with the technetium, okay, TC. So that's why it is, the full name is M99TC DTPA scan. So they label this thing with technetium, and this one is excreted by the glomerulus. Okay, so when it is excreted by the glomerulus, it provides the information about the how well the blood supply that each kidney is getting. Okay, so if, for example, one of the kidney is excreting this one late, so it can catch renal artery stenosis. So this scan is used for this thing. So this thing is one of the thing. And what about the DMSA scan? Again, they give 99M technetium labeled 99M. DMSA is dimercaptosuccinic acid. So they label it with technetium, and again the same thing. They are filtered by glomerulus, and they are partially bound to the proximal tubular cells. So when they give the injection, then they take the images, and the images basically show the size, shape of the kidney. Okay, so for example, someone who have a renal scarring, in pediatrics, again there is, I told you, vesico-ureteric reflux, and I told you that, after 6 months of diagnosing this thing, we can do some scanning. So this is the scanning. So just to check, like, if the kidneys are scarred, like there is scarring tissue in the kidney or not, right? So so we can do in this one, and pyelonephritis, to see if there is any kidney scarring. Is there any kidney scarring or not? So it is a very good technique to check the shape, the size, and the functionality of the kidney. We can do renal biopsy, and biopsy, as you know, like, simply, it is same for everything. So that's all, guys, and see you, like, next week with more lectures on nephrology. Thank you so much.